All right. I want to personally thank the members of the first panel this morning. It was absolutely amazing. Thank you to Susan for sharing her story. Thank you to all of the questions that came in. Very insightful questions that we saw a wide range of, from function to emotion to analytical, and it gives us that perspective that I was highlighting earlier that's so important for the health professionals to hear. I will tell you, I got a little lesson in perspective at the break. I was told, we're really thrilled to be here by somebody who said, I just want one little correction. I'm not a caretaker, I'm a caregiver. And I appreciate that, and it's wonderful, again, to learn, but also to highlight the importance of the caregivers in this room. So thank you to all the caregivers. I spoke this morning about the wonderful collaboration in Philadelphia, so I'm very honored to be able to introduce my dear friend, Dr. Cecelia Schmalbach, who will be hosting this next panel, Healing Smiles, Long-Term Dental Strategies After Head and Neck Cancer. Dr. Schmalbach is the David Myers Department of Otolaryngology, Head and Neck Surgery Chair. She's the director of the Temple Head and Neck Institute at the Lewis Katz School of Medicine at Temple University, and she's the chief of the Head and Neck Surgery Division at Fox Case Cancer Center. So welcome, Dr. Schmalbach.
Thank you for that kind introduction, David. As the panel is stepping up, I just want to begin echoing, it is truly my privilege to be here. I look out this morning on the survivors as well as the caregivers, and I just want to thank you. You inspire me each and every day, and it really is a privilege to get to do what I do and share in your journey. So thank you for being here, and thank you for all that you've done for our field. As you heard, this next session is entitled Healing Smiles, Long-Term Dental Strategies After Head and Neck Cancer. During our panel, we'll delve into the specific oral health challenges faced by individuals undergoing treatment for head and neck cancer and thereafter. We have a team of dental experts alongside a tongue cancer survivor. This session will offer practical advice and strategies for maintaining oral health both during and after cancer treatment. By addressing the unique dental care needs and oral complications associated with cancer therapy, we aim to improve the quality of dental care and support long-term oral health outcomes. In a moment, I'm going to introduce our panels, but the first panelist is actually each and every one of you, both online and out in this audience. We'll be addressing questions at the end, in person and remotely. Please feel free to start submitting your questions. You also have the cards at the end of your tables, and we'll have a Q&A. It truly is my privilege to be joined by Maria Fornatora. She is the Associate Dean of Academic Affairs for Temple University Kornberg School of Dentistry. In addition, her colleague, Dr. Mehran Hossaini, is the Professor of Oral and Maxillofacial Surgery, also from Temple University Kornberg School of Dentistry. And then lastly, we have Eva Grayzel. She was diagnosed with late-stage oral cancer at a very young age, 33. She had about a third of her tongue removed and reconstructed, along with a neck dissection and maximum radiation thereafter. She first shared her cancer journey at a 2003 National American Dental Association conference, and it was in that moment that Eva realized her story needed to be heard on a global scale. Since then, she has become a leading voice in oral cancer awareness, speaking both nationally and internationally at dental, medical, and survivorship conferences like this one this morning, and she provides a very unique patient perspective. She also annually presents to students at the Temple University Kornberg School of Dentistry. She founded a 6-step screening campaign to raise awareness about oral cavity cancer, earning her an honorary membership into the American Academy of Oral Medicine. Without further ado, I'm going to turn things over to Eva.
I never knew you could get cancer in the mouth. When I had a biopsy and the receptionist called me, she told me my biopsy was negative. And I literally thought to myself, what on earth could they be looking for with a biopsy in the mouth? She told me my biopsy was negative, but she should have said my biopsy was negative for cancer. I never heard those words. And when I survived treatment, I decided it was my obligation to do whatever it is I could for raising education so people know about this disease. Is it this? Oh, here we go. This is one of the most important things I learned after going through my treatment, is that a biopsy is not 100% definitive. They can take the wrong tissue, they can misread the tissue, they can mishandle it. And in my case, they read hyperkeratosis. They told me my biopsy was hyperkeratosis, like a callus on the skin, when in actuality, it was moderate dysplasia, which has a good chance of turning into cancer. So for 2.5 years, they treated me for trauma. You all know what that's about, and so you're very lucky to hear an oral pathologist speak today. If only I had an oral pathologist read my biopsy, my life would have been very different. So I work to help dental professionals educate their patients. When we go to the gynecologist, we're educated about all the women's cancers with pamphlets and booklets and posters. When we go to our dermatologist, we're educated about all the skin cancers. But why is it that when we go to our dental professionals, they are not educating us about oral cancers? So I am an advocate, and I have some postcards to give out and posters. So here's my tongue 8 weeks after surgery. It was white because it came from my wrist, and you can see how it was misshapen. But over time, 8 years after surgery, you can see the scar tissue below it that hasn't really changed. And now my tongue has what's called crenation. It's taken on the shape of my teeth. And I need to brush very carefully in all the valleys of my tongue to make sure to get out all the bacteria that may be hanging around. So they left the tip of my tongue intact. And this is what enables me to articulate my speech. One of the things that I do over time is to massage my gums and my tongue. Every few weeks I get stiff. I feel a stiffness in my tongue. And when I'm in the shower and my fingernails are short and clean, I massage my tongue and my gums and stimulate all those blood supplies that are keeping my mouth as healthy as possible. I also had what I call vocal hygiene. Over time, I have had, let's see if it shows you on this page. So that's like a normal larynx, and that one over there was my larynx. Sometimes I can't tell you what triggers it, but I get chronic hoarseness, and the hoarseness lasts 4 months. So there are techniques that you can learn for the hoarseness as well as after surgery. I used to speak like this. I couldn't pronounce my R's, I couldn't say S's, and I worked with a speech therapist who really resolved the issue. But these are the long-term effects of my treatment. So I have had 6 negative biopsies over the years, right over my graft, because somehow that tissue still wants to grow out, but they've all been negative. Of course, dry mouth. I would say my best trick is that I use a hydration backpack. I hang it on my night dresser right beside my bed, and when I need to drink at night, instead of sitting up and knocking over a glass and blah, 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 I basically just reach for the tube, which I tuck under a pillow behind my head. I know exactly where it is. I suck water, and I can go right back to sleep. But there are so many products on the market, even ones that are out here today. Don't give up on your xerostomia. There are solutions, and different products work better for different people. I have had vocal cord nodules and polyps. I have never had surgery for it. Each and every time I have done therapy that has resolved the issue. Periodontitis. Okay, let me tell you, oral cancer survivors, dental complications are going to be the hardest thing for you to deal with, and to prevent it, the best thing to do is great oral hygiene. Don't just brush and floss. Rinsing is really important, really swoosh. Keep your mouth as clean as possible. Try to brush after every meal instead of twice a day. The better you keep your oral hygiene, the fewer dental complications you're going to have in the future. And when you have a dental complication, it's not mild, it's serious. I recently had a gum graft for a perio problem, and the doctors, you know, they don't know us survivors that well. They don't know what it's like going through radiation. So this doctor told me, 2 weeks to heal. Well, let me tell you, it took me 6 weeks to heal. It happened, but it takes a lot longer than the doctors that are treating you think. And it's so important to use good products. So there are all kinds of options out there. Be careful about using, you know, baking soda or other products that you don't really know how they affect you as an oral cancer survivor. So you've got to be careful. You know, people say salt water, hydrogen peroxide. You need to discuss these things with your doctors, and also listen to your own body. You know yourself better than anybody. I have ringing in my ears, but it's intermittent and it goes away in 30 seconds. I'm pretty sensitive to light. I've had 3 basal cell carcinomas in my radiated field. They can't prove it's from radiation, but it probably contributed to it. And what else can I tell you? Let's talk about the neck. Okay, the neck. In the beginning, my neck hung to the left like this, and I had a myofascial therapist work to help me release the scar adhesions in my neck so I could keep my neck up straight. But it's so important to be in a car and make sure you have a headrest behind you. If the car stops short and your head goes back, it could really trigger a major neck incident. I tell you, sometimes I get out of bed the wrong way and I trigger a neck incident that literally gives me pain for 24 hours up into my head. Little things can trigger a lot of neck pain because, you know, you're compromised. Let's face it, I only have one neck muscle. So there are a lot of things I can't do. But from physical therapy, thank you, physical therapist, I learned that I can lift my head up out of the bed with this muscle. So if I lift my head this way, I can't lift my head. But if I turn my neck this way, yeah, I can lift my head. I have learned that my saliva, if I get into child's pose, you know, the yoga pose like this, sometimes if I sit there 5 minutes, I feel saliva coming into the front of my mouth. At night, I have learned that the side that I had my cancer on produces no saliva, but this side produces a little saliva. And at night, before I drink my water, I roll over to this side and I suck my lips, you know. And believe it or not, I can feel some saliva dripping into my mouth, and it can help me go to sleep again. So don't be curious, be experimental. You are your own body, and you're gonna figure solutions out, but you gotta be creative. And as Susan said before, reach out to other survivors, because we're all seeking solutions for these problems that, like, you think nobody else has. Okay, let's go on. What I have learned, a lot of people ask me, what have I learned from going through oral cancer? It's not about the length of your life. It's about the breadth of it. So make every day count. Spend time with people you love. Do things you love. Because you know what? We may have survived oral cancer, but everybody is in the same boat. We can all die any day. So make it a good day for yourself. I didn't think I could get through treatments. I really gave up. I went to my radiation oncologist and I said, I'm quitting. But I know that we all have this treasure chest of strength within us, and it's important to access it. Access that treasure chest and find the strength you need to get through this. Find what it is that's going to get you through it. And certainly your support network will help. And the last thing I learned is that nobody will take care of you like you. So when you need to rest, you rest. When you don't want visitors, you got to say no visitors. When you don't want flowers delivered because they give you allergies, you got to say so. Speak up and organize and help the people who are coming after you. So survivors are going to come after you, and they're coming to you for answers. So help them organize their support work and speak up for what they need. You got to ask for what you need. I learned a lot about friends. I had some friends who were just great for the good times, but when the hard times came, some friends disappeared. So I encourage all of you to look carefully when you go through treatment, who your friends are, and then spend your life nourishing those friendships. And lastly, surviving or really thriving. Thriving through oral cancer, no matter what stage you're in, it's a choice. Choose courage. Choose gratitude. Choose moments to cherish. I believe that oral cancer is an opportunity. It's an opportunity to leave a legacy to all those that know us and love us. It's a legacy of what it means to be a family, what it means to be a good friend. So we have an opportunity surviving cancer to make a difference for all the people who know us and love us, including our healthcare providers. We can groan and moan and be depressed, or we could choose those moments of gratitude, those moments of courage, and spend time with the people in your life who love you, because that's people. That's what it's all about. Thank you. She knows me pretty well.
I do. Thank you, Eva. Eva has been speaking to our dental students at Temple Kornberg School of Dentistry for the last 14 years. She's been telling her survivor story to them, and I can attest, and I bet you can now too, to how impactful her story has been in its humanity, in its inspirational quality, and the ability for it to move our students. These are our students standing up and applauding for her at the end of her survivor story. And you can see in this picture that it moves them, it inspires them. It has helped them to keep oral cancer detection on their radar long after they graduate from dental school. I can tell you that occasionally I run into alumni and they tell me their oral cancer screening stories, and they ask about Eva and how she's doing. And this is the kind of community that Eva has created, and we've heard about community from just about everyone today, and beginning with David and his discussion of the importance of community. And I encourage you to create a community the way Eva has. And her community cares about her, she cares about them, she cares about educating them using her experiences. I encourage you to consider doing the same, being part of a community. Tell your story in any way that you can to educate others, educate yourself, which you're starting, I'm sure, along the way, and especially today. Consider advocacy work. Start by being your own advocate. And I want to talk quite a bit about that today. And one way that you can do that is to learn how to examine your own mouth, looking for signs of either recurrence or new cancer if you had intraoral cancer. The idea being that self-exams for cancer screening in between regular professional oral cancer screenings and examinations, not in place of them, but in addition to them, can help you to detect changes in your mouth. And as Eva said, you know your mouth better than anyone else, and so you will be able to identify things early and bring them to the attention of your healthcare provider. So Eva has a 6-step screening that you can access online. But what are you really looking for? And so I wanted to talk a little bit today about what does precancer look like. A vast majority of oral precancers present as white patches that we call leukoplakias. And they present as these wrinkled or pebbly areas. It can present absolutely anywhere in the mouth. And you can see 4 examples here, the first being at the corner of the mouth, the next being on the underside of the tongue, and then between the cheek and gum, and then the place where the tongue meets the rest of your mouth, that's called the floor of the mouth. Any of these white patches, and on the right, under the tongue and the gum area, that has a little bit of red associated with it. When you have the red, it's called erythroleukoplakia. So anytime you see anything like this, you want to try to wipe it away. It should be non-wipeable if it's a leukoplakia. So 90, roughly, % of oral precancers look like a white patch or have a white patch associated with them. But the important areas, the areas that we know have a higher chance of developing cancer, are those on the side of the tongue, underneath the tongue, and where the tongue meets the rest of the mouth, which is the floor of the mouth. So you want to pay particular attention to those. And unfortunately, those are a little bit hard to see, a little difficult to examine. But again, some online resources for how to actually do the exam. If you're doing the exam, you should know that there are common precancer lookalikes, white, non-wipeable things that can happen in the mouth. The first one there is you can have a line on the inside of your cheek that is right at the level of where your teeth come together. This is of no consequence. It is just a little friction when you chew and talk that occurs that level, and it gives you a little bit of a callus and a line there. Nothing to be concerned about. You can also get whiteness on the top of your tongue. And so in that second picture of geographic tongue, you can see some whiteness and some circles and ovals. You might have geographic tongue. It is extremely common, and it is of no consequence. It doesn't turn into anything else, but it can make the top of your tongue look more white or more red or combined. And it changes every couple of days, and that'll give you a clue that you're dealing with something that's not cancer, because that won't change in a couple of days. Or you could have a yeast infection, cheesy, curdy material in your mouth. Or if you use smokeless tobacco, at the site that you place the tobacco, you can get a little bit of tobacco pouch keratosis, which is like this translucent fissuring at the site. Again, this should be reversible. If you move the tobacco or you quit, it should go away entirely. But how do you make a diagnosis? If there are things in the mouth that are white and non-wipeable, how can you tell the difference between those that are leukoplakias, true leukoplakias, and then other things that you don't need to worry about? And the answer is really doing a scalpel biopsy, a biopsy like the way Eva talked about. Biopsies are really still the gold standard. Surgeons do biopsies. Most general dentists do not do biopsies, so if they see something, chances are good that they'll refer you to an oral surgeon, a head and neck surgeon, an ENT to have that biopsy done. It can be scary, but there's really no way to look at a white lesion and tell you whether or not it's precancer or even cancer without doing a biopsy. And multiple biopsies are sometimes needed. Eva alluded to that. If you have something very large, the way I have image there, where there's a large portion of the inside of the cheek or a large portion of the side and underneath the tongue that's involved with this white and red area, best to take multiple biopsies because you don't want to miss the worst part of it. You don't want to underestimate what's happening there. And then, what are the common biopsy results? So commonly, if you have a white leukoplakia in your mouth, chances are good the biopsy result is going to be either epithelial dysplasia or hyperkeratosis. And, unless you're a pathologist, you are not going to know what that means. And epithelial dysplasia is, when we look at it as a pathologist, when I look at something under the microscope, if it looks like precancer in a leukoplakia, it's going to be epithelial dysplasia. And then we tell you how severe it looks. So mild, moderate, severe, or very severe, which is carcinoma in situ. This means that under the microscope, it looks like precancer. Hyperkeratosis, in contrast, looks kind of like a callus to us under the microscope. So these two things are fairly different. However, both diagnoses indicate that there's something abnormal about the tissue, something abnormal, and then how is it going to be treated is usually dictated by the biopsy result. A mild dysplasia or a hyperkeratosis can have a number of choices for how you manage it because it's not necessarily going to turn into cancer the next day. So smoking cessation, tobacco pouch keratosis, for example, you could move the tobacco or stop using it. Excuse me. And again, if you're doing a cancer screening on yourself, what does cancer look like? Again, many oral cancers will look like a white patch or a white and red patch, or a growth, a tumor, a mass. So on the left side, you see a lot of white and red patches. On the left side, on the right side, you see there's particularly one that looks like a mass. It's kind of growing over the area where the teeth were extracted, where a denture might sit. And then the third way a cancer can present is instead of growing out, it grows in, it burrows into the tissue. So the two pictures of the tongue there are of a sore or an ulcer at the site where it started and began to burrow in. And so a persistent ulcer is one of the signs of oral cancer. Persistent beyond 2 weeks, you want to consider what is the cause of that. Because most sores in the mouth do resolve on their own within a week or two. So you've all burnt the roof of your mouth with a hot cup of coffee or accidentally bit the side of your tongue, so a thermal burn, a traumatic ulcer, goes away in a couple of days. Canker sores, same thing. They can be painful, but they'll go away in a couple of days. If it doesn't go away in a couple of days, you want to consider showing it to your professional, whoever you're seeing, be it a follow-up with your surgeon or your dentist. So again, when are we going to be concerned? When you're doing a self-exam, anything that lasts beyond 2 weeks, anything that lasts beyond 2 weeks, bring it to the attention of a professional. It may or may not need a biopsy. You're certainly not a professional, but you're able to monitor changes in your oral cavity. And the highest concern that we have is for anything that's on the side of the tongue, underneath the tongue, or the floor of the mouth. And you can't tell just by looking. So the two pictures there, the top one, that's a precancer, and it looks pretty innocuous. The bottom one, that's just a hyperkeratosis, just like a callus. And the only way we know that is by doing a biopsy. So I'll leave you with a quote from Mother Teresa: "If we have no peace, it's because we've forgotten that we belong to each other." And again, this goes back to community. And I hope that each of you find peace and healing in each other and in the communities that you have and experiences like this. Thank you.
Good morning. I talk loud, so if I talk too loud, let me know. But again, I'm Mehran Hossaini from Temple. Thanks for the invitation. And I have to admit, I think when we talk about head and neck cancer, I think many people think about it as like one kind of cancer, and it's really not. It really, in many ways, depending on the location of the cancer, it differs. Its quality, how it responds to treatment, some of the characteristics that it has, some of the signs and symptoms it has, and some of the long-term challenges that we deal with. So, by the way, to kind of be clear, these lists are really my observation, and I'll tell you why. Every time I have a cancer patient, and I've been treating, my first cancer patient was in 1991, so I've been around long enough, and I guess my loss of hair shows it. But every time I have a cancer patient, I tell them I have absolutely no idea what you go through. And I don't think any of us can, and those who say they can, I don't know. And the fact of the matter is that, as healthcare providers, we can't say, oh yes, what are the objective findings, what are the anatomical issues, this, that, and the other. But a lot of the time, we truly don't sense the human cost of cancer. So again, so these are my observations, but these are some of the things that I know that my patient complain about. And as you see, there are some commonalities. For example, the chewing and speech, dry mouth. These are, of course, a lot of the common things that we see. As was discussed, some of the congestion and kind of lymphodemas and things of that nature. So depending on what kind of cancer or what area you have a cancer in, you are going to have many different symptoms for those who haven't experienced it, and for those who have, you know how troubling some of these can be. And I think something we talk about a lot is xerostomia, dry mouth. And I have to admit, I mean, I have to give a shout out to our radiation oncologist. I think if you look at our patients for the last 25 years and compare them to the patient that we used to see back in 90s and 80s, for those of us who have been around long enough, you haven't seen dry mouth until you see some of our older radiation patients. But certainly within the last 25 years, our radiation oncologists have done tremendous work trying to help out of our patient. And in case you're wondering what's going on, is that in this picture you can see that we have three main salivary glands that provide most of the secretion and the kind of a comfort that we have in our mouth. And those can often be affected by radiation. And of course, when the radiation dose gets higher, there's more damage and more risk of dry mouth. So what's the big deal about dry mouth? For those of us who haven't had cancer, I've been dehydrated, it's no big deal. You know, I can drink some water and stuff like that gets better. For our cancer patients, not that easy. Anywhere from basic stuff, loss of taste, imagine the things that you ate for breakfast and you all had your favorites and stuff like that. They all taste wonderful. But, you know, with dry mouth, that changes completely. To just the simple comfort, you know, kind of like, you know, your lips don't get stick together and your tongue can move around and things of that nature. So dry mouth, for those of us who have not had cancer, we kind of say, dry mouth, so what's a big deal? For a cancer patient is has a tremendous impact on quality of life, aside from some of the other things that results into. And again, if you look at these pictures, I don't know if you can see them far back enough, but again, these truly some of our patients, sometimes the dry mouth is not necessarily dry, but the different characteristic of the saliva impacts, you know, the sensation and the functionality of our patient. And sometimes the patient are just dry, and that's the problem. So again, the reason I give a shout out to our radiation oncologist, because again, within the last 25 years, they've been doing tremendous effort to kind of avoid those three salivary glands that I was showing you and try to avoid them to get excessive radiation. And they actually kind of plan the radiation dosage. So, for example, half of the gland gets as much radiation. So this way, improving our patient's quality of life. So again, if we can prevent them, that will be perhaps the first step. There are a lot of home remedies, anywhere from, you know, all my patients carry a water bottle or some kind of water container with them. And again, that's, you know, kind of like maintaining that moisture that goes a long way. There have been a lot of different mouthwashes. And again, the reason I said, I started my conversation with me telling my patient, I have no idea what you're talking about. I think there was some question earlier, how can we predict these things and fix them? I've realized that part of this stuff is objective, part of it is subjective, meaning that we talk about, biotin and all that kind of, you know, different, mouthwashes they can use. But in reality, how our patient respond to it is quite variable. I have some patients who find it amazing. Oh my God, it was life-changing. And I have patients, they go, is not doing a damn thing. So I guess the point I'm saying is that, again, we do have some remedies, we do have some objective things that we can try to address, but in reality, our patients respond to them very differently. There are some prescription drugs that are used. The problem is that, you know, a lot of them have many different side effects, and then many of our patients do have other comorbidities, and they're taking other medications, stuff like that, and can just make things even worse. So that's why none of us, you know, if you Google it, you go, oh my God, there's this medication that I can use and increase the secretion of my saliva. And if you ask your doctor, the doctor's probably say, I don't think that's a great idea, again, because number of other side effects that provides. So again, it's one of those things that kind of challenges us. In case you're wondering what I'm talking about, the radiation issue, is that this is what we call IMR2, or intensity modulated radiation. So if you look at these different color line, these are the different areas that are getting different doses. And because of that, we can, for example, spare some of the salivary glands and hopefully help our patient if we can, if it's possible at all. So the question becomes that I think the mention was that can you have dental treatment? And the answer is absolutely yes. You should have a lot of dental care, certainly prior to cancer treatment, and definitely afterwards. And anywhere from basic stuff, cleaning and things of that nature, and avoiding infections and all that kind of stuff, to fluoride trays and things of that nature that can help with the formation of cavities and things of that nature. So certainly dental treatment is safe. So please do get care if you have not. Is oral surgery safe? And that's a big maybe. And I'll talk about that a little bit. So, certainly any kind of oral surgical procedure like removal of teeth, I think it was mentioned about their wisdom teeth, and having hyperbaric oxygen. We'll talk about that a little bit. But certainly anything that needs to be surgically invasive should be really done prior to radiation. And after radiation, we have to kind of talk about it. The reason I put this IMRT image here is that as a surgeon, I kind of need this information. So for example, if you look at these color lines, where the radiation has affected the mandible, for example, and I know that some of the areas have not been radiated, therefore I can treat those areas safely, and some of the other areas I cannot. So this information is very critical, at least in my practice, for my patients. So you may say, well, what's a big deal? Kind of like, surgery. My friend did it; they were fine. What could go bad? And I want to point out the pictures that you see on the bottom. So this is essentially the rabbit jaw that on the A side is pre-radiation and on the B picture is after radiation. I don't think you have to be an expert to know that the white stuff, essentially blood flow, is significantly reduced. So essentially that's the problem. So for our radiation patient, there's significant reduction in the perfusion of the soft tissue, bone, et cetera, et cetera, et cetera. And the reason, and so anytime you cause an injury, i.e. extraction of a tooth or any kind of surgical procedure, it can potentially cause an environment that you don't have any healing potential. So again, it was mentioned about hyperbaric oxygen, and I have to admit, hyperbaric oxygen, when it came out back in back in 70s, it was thought, oh my God, that's the best thing that ever happened to a human being. But having said that, we haven't necessarily seen that, meaning that it is possible, it is an appropriate treatment, but we don't necessarily see that it helps all our patients. But essentially, it has single chamber or multiple chamber setup where we can expose our patient to extra oxygen. So can I replace missing teeth? And the answer again, well, yes, kind of. And the reason being is that after cancer therapy, we do reconstruction of the soft tissue and bone, but the problem is that that doesn't necessarily replace the anatomy very well. So again, these three pictures show three of my patients that have had successful management of cancer, but because of the change in anatomy, they are very difficult to actually get conventional treatment. So the only way we can treat these patients oftentimes with implants and things of that nature, which can kind of create a different environment in terms of cost challenges, expertise, and things of that nature. So I don't know. I call myself a pessimist, but I think I'm probably more of a realist. I think you can be pessimist about these things and say everything bad can happen. You can be very optimistic and say, great, I'm going to be absolutely wonderful, and I'll get through this. But I'm a realist. With my cancer patient, I've noticed that we have some very good days, we have some horrible days, and some days in between. And I guess I have to kind of, prepare myself to help them out during all these things. Thank you.
So again, we want to hear from everyone, both in our audience and those that are online. I'm going to just start and piggyback Dr. Hossaini. There were several questions about HBO, and you addressed that with respect to tooth extraction. One of the questions from an online audience member was, do you find in your experience that it helps with the post-extraction pain and healing?
Am I on? So HBO has been, over the past number of years, 30, 40 years, we have kind of gone a lot of back and forth, that it is completely curative, doesn't help that much, and somewhere in between. And again, at least in my experience, some of my patients have benefited from it amazingly, including post-operative pain, including wound healing and things of that nature, and some of my patients have not improved by any means. Actually, I've had a number of patients who have had osteoradial necrosis even after full course of hyperbaric oxygen. So what I do, I tell my patient that I have hyperbaric oxygen. We can use it. Let's try it. I'm hoping that improve your your symptoms, but there's no guarantee. I think one article that I had read, it said something like it improves about 25% of our patient. The problem is that we don't know which 25%.
I have had 3 series of hyperbaric oxygen. The first time was for a split lip that wouldn't heal, and it healed it immediately. And then the other 2 times were for prep for implants. So I have had implants in my radiated bone, and they have given me a great quality of life. So it is possible, but I have met other patients who have had cancer cells still in their body. And you can correct me, but I have the impression that if you have cancer cells in your body and you have hyperbaric oxygen, it could make the cancer cells double and triple, and you get sick pretty fast.
Thank you.
There have been some reports of that.
Okay.
We have a question in the audience.
Hi, my name is Hathaway. I am an 11-year-old survivor of cancer. I had cancer before of my nose and my tongue. I'm here just to draw attention to the dental issues most of you will have going forward. My dental issues did not start until year 6 or 8. I was fortunate that I had an oral medicine dentist right after surgery to help me with my dry mouth. Now, the long-term effects in your mouth are horrible, but I encourage everyone here to see a dentist regularly, to see a dental hygienist, get your teeth cleaned every 3 months. They can pick up any abnormalities in your mouth. I can't have dentures or implants, so I'm okay with that. I think our goal is to educate fellow survivors on dental care. I didn't know what an oral medicine dentist was. I didn't know what a orthodontist was. And unfortunately, as you progress, you'll need to find these specialists. I belong to a very small group of volunteers. It's called MOPS, Massachusetts Oncology Patients, Survivors, and Supporters. And our goal is to have dental care covered by insurance. You talk about prescription medication. That is not free. Anytime you go to the dentist, it can be thousands of dollars. A root canal, $1,600. Insurance, a $2,000 limit per year. This does not help us. I would like to see everyone here be involved in advocating for insurance coverage to dental care for survivors. After all, medical created these issues. The dentist students is medical. All the treatments we went through. I could go on for a half hour.
I'd like to respond to you that when I needed dental implants when I was in my 30s, the insurance company said, we won't pay for implants, we'll pay for dentures. And I said, well, I'm only in my 30s, and if you don't stimulate the bone, over time the bone is going to recede and there's going to be no possibility of implants. So I tried fighting with them. They wouldn't give me any money, so I paid for it myself. But I have learned that if you if you keep on that insurance company and you go right to the top, get the name of the head of the company and tell them your story, which is what I eventually did at one point, the CEO of this particular insurance company said, I would have covered it for you. And I said, why? He said, because there's so few of you that it would have been easy for me to just cover it. So keep fighting for that insurance.
Excellent, and congratulations on being a survivor. And you actually answered one of the online questions about how to gain more knowledge, and it really is from just being an advocate and sharing your story, and there are a lot of online resources. Dr. Miyamoto?
Hi, I'm Susan. I'm a cancer survivor of 6 years. I'm from Florida. I had my cancer treatment here at Jefferson, and I happened to sit right next to my oral cancer doctor. It was so weird. I didn't even recognize him, Dr. Curry. It was so fun. So that was really neat. Okay, so I may have just kind of get overwhelmed with information, but this was about pulling teeth on radiated bone. And I think what I heard you say, I'm sorry, your name escapes me, but that's not a good idea. That's not a good idea. But I've got 2 molars, and they told me they're dying, and I'm sure they're dying because the radiation was on the right side, right here. Do I just let them fall out?
So to make a dark comment, sorry, the risk of osteoarthritis necrosis is about 7%. When we extract the basic tooth or something like that, you actually have about 9 to 10% risk of infection, but we do it all day long, right? The problem that we worry about osteoarthritis necrosis has nothing to do with how readily it happens, rather what a negative impact you have on quality of life. So meaning that if you get an infection after like a regular dental extraction, we give you some antibiotics and a week later you're fine. If I extract the tooth in a radiated field and you do become one of those 7% that get a osteoarthritis necrosis, the impact is, from many different ways, is not measurable. So to be honest with you, can you have an extraction on the radiated bone? Probably, within that 7%, you may not. So in my opinion, I'm not a gambler. I've been terrible at gambling. I never go to Vegas. But I guess the gist of it really becomes that what kind of gambler you are. If you feel that 7% is negligible and, nothing's going to happen, I guess, statistically, you cannot argue with that.
Well,
unfortunately, if it does happen, so then the question becomes, what do you do with those teeth? Many of us essentially say, just let them fall out, or pretty much cut them down at the bone level, and then actually the bone kind of little by little heals over it and kind of goes back.
Okay. I can't tell you how that, I can't even say the word, how it scares survivors. It's horrible when I heard about it. It's just so scary. So even 7%, I don't want to stay away from anything risking it, probably.
And thank you for sharing your vulnerability. To piggyback, and it really segues nicely into an online question, asking, how do you find someone that specializes and is comfortable and knowledgeable about irradiated mandibles in our cancer patients? And I would advise you to start by talking to your surgeon and or your radiation oncologist. That they should be able to give you names of both dentists and oral surgeons who are very familiar. And in that sense, hopefully that takes away a bit of the fear. Again, I appreciate you sharing that. And I can just add, as a head and neck cancer surgeon, there's a gentle balance. People do get very sick and can die from dental abscesses. So please, again, just to echo all of the comments from the panel, seek out your dentist. The dentist is not going to want to treat you if they're not used to radiation. I promise you that, and they will get you tied into another colleague. So don't let your cancer own you, but go out, and if you're concerned about a tooth, please seek out the care. Start with your dentist, start with your team. Yeah.
I'd like to say that there's a lot of crossover in dentistry. As a patient, my general dentist will say he does perio and implants, when you should always get an opinion by an expert. like Dr. Fornatora here, she's an expert on oral tissue. So why would your biopsy go to a general pathologist when it can go to an oral pathologist? So it's the same in dentistry. There's prosthodontists, there are periodontists, as our survivor here was just saying. And it's really important for you to figure out, as this question was asked, who is best for you and what you need and how much experience have they had. I mean, Dr. Schmalbach, even in head and neck cancer, there are some surgeons that do a lot more of one surgery than another, and you want to go to the surgeon that does what you need. So it's really important to get second and third opinions.
Great. I know we're getting ready to segue shortly into our next panel. I think we have time for at least one more question.
Actually, two things. The young lady up front there that had problems getting coverage with her insurance, I was a trustee on a Teamster Health and Welfare Fund. Appeal, appeal, appeal. That's all I can say. My question, for those of us that are walking around radiated and suffer from summer teeth, some are here, some are there, do we only have to go through 60 dives and then we can have them all yanked and never have to have hyperbaric again, or is that not true? And when you're told that you're not a candidate for implants, will that ever change?
I'm going to throw that to Dr. Hossaini.
So I think, as I always say, you really have to look at the radiation map. So every time I have a patient for implant or any other treatment, that the first thing I do, I contact Dr. Miyamoto or Dr. Galloway at Fox Chase or our colleague at Jefferson. I need the isodose maps to essentially some of those pictures that I was showing. That what are the areas and how much radiation they've received. If they have received under 5,000 centigrade of radiation, most of our patients we can treat relatively safely. If they have done more than that, then it's not. So, and then again, goes back to what planning we can do. So I guess the gist of it goes back to, unfortunately for cancer patient, you can't just go down to the, with no disrespect to anyone, you can't go to the dentist around the corner and say, hi, I'm here and I want this. You really should kind of talk to your radiation oncologist, your head and neck cancer. Most of them have connection with some of us who treat a lot of the cancer patients, and we know how to manage them safely. So I guess that's the best. So I guess you can't say that you are not, absolutely not a candidate. And that's why I said maybe.
Great. Well, I want to thank all of the panelists for sharing of their expertise. For those, if we didn't get to your question, rest assured they'll be answered online. You will be heard, and we'll make sure you get the information that you need. So